The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining the RLS Foundation's webinar titled RLS and Depression. My name is Zibby Crawford, and I'm the Marketing Coordinator at the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Koo will answer as many questions as time allows at the conclusion of his presentation. After the webinar, you will receive an email with a link to the recording. The recording will also be made available in the member portal of our website. If you are not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting they may have RLS or are experiencing a change in their symptoms should always consult a qualified healthcare provider before making a change in their current treatment plan. Information offered in this webinar is for informational purposes only and should not be considered as a substitute for the advice of a physician. Visit our website to find an RLS healthcare provider near you. Dr. Koo is the director for the Yale Center for RLS and RLS Foundation Certified Quality Care Center, as well as the chief medical director of Sleep Laboratory at the Connecticut Veterans Affairs Healthcare System. Dr. Koo is an associate professor of neurology at Yale University and has been an active member of task force and section committees related to the sleep-related movement disorders in the American Academy of Sleep Medicine. At the Foundation, he serves as chair of the Medical Bulletin Committee and the medical editor for Nightwalkers. Dr. Koo is board certified in both neurology and sleep medicine, and much of his research lies in those categories. His research on RLS and PLMS has included animal modeling, epidemiology, and human genetics. Dr. Koo recently was awarded a grant from the Department of Defense for his work on RLS and melanocortin hormones in patients with moderate to severe RLS. Dr. Koo, thanks for sharing your time and your expertise with us today. I now invite you to begin the presentation.
Well, thank you very much, Sibby, for that nice introduction, and good afternoon or good morning to everybody. I know there are people from different areas in the country. So we're going to talk a little bit about depression and anxiety in restless leg syndrome. So first, we're going to talk a little bit about the quality of life in restless legs, the epidemiology of restless legs and depression, potential mechanisms which join these two things to restless legs, some clinical issues when one is being treated or seeking treatment for depression in the setting of restless legs, and then finally we're going to talk a little bit about a study that we have recently published about suicidality in the setting of restless legs. So I don't need to I don't need to remind people of the 4 essential criteria of restless legs, because unfortunately many of you experience this firsthand. These are the criteria, the essential criteria to diagnose restless legs. They're very stereotypic and they're seemingly simplistic, but these seemingly simplistic symptoms in the legs have far-reaching impact across several body systems. They have effects on the cardiovascular system, the symptoms of restless legs, as a hazard ratio of cardiovascular mortality can be increased. There is impact on the peripheral vascular system, as there might be impaired microvascular circulation in the legs. The endocrine system is impacted. We're just finishing up on some studies which are showing that restless legs seems to be associated with hypothyroidism, and of course the studies that we have been funded to look at the melanocortin hormones. The peripheral nervous system may be impacted, and finally the brain. As you know, restless legs is very tightly associated with insomnia, having effects on sleep, and also, unfortunately, very well tied into effects on mood, and unfortunately deleterious effects on mood. And this is what we're going to talk about today. So the criteria for restless legs about 7 or 8 years ago were changed a little bit. You know, it still included the 4 essential criteria, but in addition to ruling out other mimics of restless legs, things that can also produce an urge to move, like leg cramps, also experts knew the importance of having some sort of distress, daytime or nighttime disturbance. So symptoms must cause concern or distress, sleep disturbance, or impairment in mental, physical, or social, occupational, or other areas of functioning. So very early descriptions of restless legs, one of the earliest descriptions was in the 17th century by the Dr. Sir Thomas Willis, and I'm just going to read to you. Some of you might have read this or heard about this description. Wherefore, to some, when being in bed, they betake themselves to sleep, presently in the arms and legs, leaping and contractions of the tendons, and so great a restlessness that the diseased are no more able to sleep than if they were in the place of the greatest torture. So I think the use of this word torture is quite fitting. I've heard this word used by a number of patients to describe what their symptoms are like, and unfortunately, the listeners on this webinar know. But you know, and one could imagine if you're trying to fall asleep and rest in bed, but you have this intense urge to move, that's got to be pretty horrible. So another early description in the 19th century, this is a German physician. Part of his book, this is in German, but part of the book was talked about this anxietas tibiarum. And basically what that means literally in Latin is anxiety of the legs. And he proposed that it be classified as something called a neurasthenia, or a condition with the symptoms of fatigue, anxiety, neuralgia, and depressed mood. So these kind of descriptions of an association between these strange symptoms in the legs and depression, anxiety really date back, you know, many hundreds of years, and co-occurrence of restless legs and depression. So more contemporary studies have looked at this, and the earlier studies looked at kind of depressive symptoms and also quality of life. So here are a couple of studies. The panel on the left is a study done in Sweden, and it's kind of a busy study, but essentially I've underlined a couple of the symptoms of depressed mood and isolation, and it included men with restless legs and men without restless legs. And the study noted that if you had restless legs, you had about a 2.6-fold chance of having depressed mood, and also a 2.6-fold increased chance of having social isolation. So in the right-hand panel in this American study, this is again a large study with about 1,800 men, and they noted that in about 40%, so again underlined is poor mental health all days of the previous 30 days, a very high percentage, 40% of these men that had often or very often restless legs felt that they had poor mental health for all days of the last month. So this is a very large study. This was conducted by across numerous countries, across a couple of continents, led by Richard Allen, the Restless Legs Epidemiology, Symptomatology, and Treatment Study, or the REST study, that looked that aimed to look at the prevalence of restless legs across different countries, but also kind of the societal and the behavioral impact of restless legs in these people. And so it was a very large study, as you can imagine, about 16,000 people. In the first table, it says table 2, you can see that the prevalence across these different countries, yes, France, Germany, Italy, Spain, and so forth, any frequency of restless legs really ranged from about 5 to about 10%. Restless legs that occurred twice per week and was combined with at least moderate or extreme distress was about 2 to 4%. So 2 or 4% of a population is still pretty common and pretty prevalent. And then if you consider those people that had restless legs at least twice per week and rated their symptoms of at least to be moderately distressing, you could see that a high percentage of them had, so about 50% of them said that their symptoms had a negative influence on their mood. They lack energy when they suffer from the symptoms. The daily activities were disturbed. A little bit less so, but a little bit more than a little bit more than a quarter felt that their social life was affected, and they get feelings of desperation. So you can see that, you know, in these, even in these earlier studies, there was a lot of focus on symptoms that affected mood and well-being. So in this same study, in the REST study, they also looked at quality of life, and they did so by using highly validated scales to look at quality of life. And one of the most commonly used validated scales to look at quality of life is the SF-36. And this is a battery of many, many questions that looks at quality of life across several domains. You know, we could just read off the domains: physical functioning, role, physical, bodily pain, and then if you get over more toward the right is more of the mood and the psychological kind of symptoms, emotional role, and mental health. And you could see that in the filled in circles with the lines is kind of an age and sex adjusted norm, and in the gray columns is where patients with restless legs fell, and in all of them they fell below what the norms were. For physical functioning, perhaps more, but also significantly below the age sex match norms for mental health and emotional well-being. And they transposed this graph. Again, the restless legs people are the dark circles with lines, and you could see that when they compared it to people with type 2 diabetes, osteoarthritis, and depression, RLS people fell a lot of times below, or if not within par of people with those other diseases, except for, you know, as you can imagine, people with depression failed a little bit less well for emotional or mental health than people with restless legs. Okay, so these are early studies that kind of looked at quality of life and psychiatric symptoms. There have been a few studies that have looked at specifically at psychiatric diagnoses using, at the time, the DSM-4, which is the Diagnostic and Statistical Manual for Psychiatric Disorders. And so this was a German study, and they titled it Anxietas tibiarum, after the Dr. Whitlock from the 19th century who described this. And this is a little bit of a busy slide, but let's just take the top table, which looks at the prevalence or the occurrence of within 12 months. And if you look at MDE is any major depressive episode, about 18% of people with restless legs had any major depressive episode, and this is within 12 months, as opposed to 9% of controls. And if you compare the two, people with restless legs had about a 2.55-fold increased likelihood of having a major depressive episode within 12 months of the point estimate. And results were similar for many of these other psychiatric diagnoses. So dysthymia is kind of a low level of, it's not major depression, it's kind of a low level of negative mood or feelings of sadness. That, you know, if you look in the rightmost column there, wasn't quite associated with restless legs, but having panic attacks was about 3-fold increase in people with restless legs. Having GAD is generalized anxiety disorder was about 3.5-fold increase in persons with restless legs. And then they combined a little bit of some of those. And so in the bottom panel is a lifetime prevalence of these psychiatric again, MDE's major depressive episode, persons with restless legs, about 36.9% of them had a major depressive episode in their lifetime, compared to just 15.2% of persons without restless legs. And if you compare the two, it's about 3.3-fold if you had restless legs. Again, dysthymia was not associated with restless legs, but certainly panic attack or any panic disorder was significantly increased in persons with restless legs. This is an American study conducted by Dr. Lee and colleagues from Johns Hopkins, and they found something quite similar. And so again, MDD is major depressive disorder. They also split it into lifetime versus 12-month, and interestingly, they found that lifetime, your likelihood of having a major depressive episode was less during your lifetime, but more over the last 12 months compared to a person without restless legs. So you can see panic disorder, there was a five-fold increase over a lifetime, 13-fold increase over the last 12 months. Panic disorder and major depressive disorder also were very increased. And having any DSM-4 diagnosis was almost four-fold increase over someone's lifetime if they had restless legs versus didn't. So I've, because of these studies and also having seen many patients with severe restless legs and a lot of the torment that they unfortunately have to endure, I've become interested in this relationship between restless leg syndrome and depression and/or psychiatric symptoms. And so I was involved in a study which aimed to look at kind of mechanisms underlying the association of restless legs and depression. And so we used data from a large cohort of elderly men called the Mr. Ross cohort, in which there were about almost 1,000 men who were assessed for restless legs using the International RLS Study Group criteria and also the severity scale. And also they had sleep studies and had PLMs measured by the sleep study. And also they filled out a geriatric depression rating scale. And so the geriatric depression rating scale, one has to answer all of these questions. And, these are all symptoms that are suggestive of depression or feelings of sadness. And the higher you score, the more likely it is that the person taking the scale is depressed. And so, so the results, I'm going to take you through this, is maybe a little bit confusing, but I'm going to try to distill it for you. So essentially, when we compared people with restless legs, so people with restless legs, they had this international RLS severity scale of greater than 12. Some of you might be familiar with this scale. It's a scale that is based out of 40. It is based on 10 different kind of symptoms of restless legs, and you answer 4 if they're very severe. So anything greater than 12 is at least mild restless legs. So if you compared persons with mild restless legs to persons without restless legs, there was a 2.85-fold increased likelihood of having depression. And so what we did in this model is, these are statistical models in which you put in a number of variables such as demographics, age, and race, and other things like alcohol. But in these final models, we also added in measures of disturbed sleep. And so when we added these measures of disturbed sleep, you can see that the association between depression decreased a little bit for when we added in sleep efficiency and sleep latency. And what we interpret this to suggest is that there is some mediation of the effect between restless legs and depression by sleep or disturbed sleep. Okay, and the idea behind symptoms mediating the association between restless legs and depression is similar for these data. I'll explain. It's a little bit technical and confusing, but bear with me. I'm going to try to explain it to you. So basically, in this graph, what you see, so the outcome here was a number of depressive symptoms. So on the y-axis here, you have the number of depressive symptoms: 0, 1, 2, 3, 3.5. On the x-axis, you're split into kind of two groups based upon your periodic limb movement index. If you had a low periodic limb movement index, you're in this left-hand group. If you had a high periodic limb movement index, you're on this right-hand group. And so also, even among these groups, you can see that there are 3 subgroups. The lightest gray is they didn't have restless legs. In the middle gray group, they had very, very mild restless legs. And in the darkest gray group, they had at least mild to moderate to even included some severe people with restless legs. And you could see that only if you were in the most severe group of PLMs, if you had a lot of PLMs, but you also had severe restless legs, was there an association between the number of depressive symptoms. So even if you had kind of severe restless legs, but if you had a low number of PLMs, you didn't necessarily have any more depressive symptoms. And similarly, if you had a high number of PLMs, but a low severity of restless legs, you also didn't have a higher number of depressive symptoms. It was only if you had at least moderate restless legs and a high number of PLMs. And so again, we kind of took this, we interpret this as a mediation of the association between restless legs and depression by PLMs. So, you know, this is a summary of it. It's a little bit confusing, but based upon that study, we took the data as suggesting that there clearly was an association, a very strong association between restless legs and depression that we found in our study, which has been found by many studies, and so we just confirmed this. But we took it one step further in that we showed that there was some mediation of this relationship by sleep disturbance and or PLMs. So this is a very busy study from this, a slide from this same study. I don't have to explain this much to you, just that in this study, patients were on a lot of different antidepressants, okay? We don't have to worry about if they had moderate or severe restless legs, but the one good thing was that, so what I did was I looked within patients with restless legs. If you were on an antidepressant, you had fewer depressive symptoms, okay? And so this is what this bottom kind of number is. If you had restless legs and you were not on an antidepressant, you had 4.3, an average of 4.3 depressive symptoms. If you had restless legs but you were on an antidepressant, you had 2.3 depressive symptoms. And so I think this is a good segue into the next area which I'm going to talk about, which is clinical issues in the relationship between RLS and depression. So often when I'm talking to folks about the association between RLS and depression, they're usually clinicians. You know, I'm usually talking to physicians or nurse practitioners or so on. And so I often advise people when they're seeing patients with restless legs, take a depression history. You know, ask the simple question, I guess not so simple, but the directed question: are you depressed? Do you have feelings of sadness or depression much of the time? And I often will advise people on how you assess for severe depression. So the kind of the most severe symptoms of depression, or some of the symptoms that reflect severe depression, are anhedonia, which is the inability to feel pleasure. So normally when people, for example, get together with a friend, or they might see a movie, or they might go out and play a sport or something, you know, we do these things because they're fun and we get pleasure from them. But if you do that and you're not able to feel pleasure, that's anhedonia. Also, feelings of hopelessness and helplessness are indicative of very severe depression, and of course, suicidal ideation. So, because this webinar is directed not toward caregivers, but to you, the patients, it's important for you to talk to your doctor. So the doctor might not know to ask about that. So this could be a primary care doctor, it could be a restless legs physician, it could be a psychiatrist. You should bring to their attention, if you are feeling these symptoms of sadness or depression, you should bring that to their attention, and then you should also seek the appropriate care. So sadness and depression are probably best treated by a psychiatrist in combination with a psychologist. So if you are feeling depression, whether or not it's related to your restless legs, it may or may not be, it is good to seek the care of a psychiatrist and a psychologist. When you do seek the care of a psychiatrist, it's very important for there to be some communication between the psychiatrist and the person and the caregiver taking care of your restless legs. But you also have to realize that, and I know restless legs patients are very good at being their own advocates. You also have to be an advocate and have the knowledge of, for example, what medications might make your restless legs worse. This is not known very well at all by your average primary care doctor, psychiatrist, and unfortunately, even your average sleep physician does not know this. So you have to be your own advocate. So you have to know which medications you can try and which medications you should never try. And so I would urge you to get a list of these medications from the Restless Legs Foundation. We talked about consider getting a psychologist. You should also consider seeking the help of a restless leg support group, because you're going to have people that are in these support groups that are going through the same things and may have more experience about where to seek help. And so we'll talk a little bit about what antidepressants you should not take, what antidepressants may be okay. And so this slide is important. So mirtazapine is probably the worst antidepressants. I suspect, I heard there are about 300 callers, people that are broadcasting in. I would guess that about 20 to 30 of you are on mirtazapine. If you have restless legs, you should not be on mirtazapine. And unfortunately, it's very, very commonly prescribed for people with restless legs because mirtazapine is really sedating. And the caregiver thinks that or not the caregiver, the care provider thinks that they're going to help the person with restless legs who has insomnia because it's going to help them sleep. But the thing about mirtazapine, it has large antihistaminergic effects. So any antihistamine is going to make your restless legs a lot worse. So the prototypical antihistamine is, of course, Benadryl. So many of you know not to take Benadryl, but you should not take mirtazapine. You should not take most tricyclic antidepressants. So TCA is just an abbreviation for tricyclic antidepressant. Doxepin, also very sedating, so might be offered to someone with restless legs that has insomnia. You should not take it, okay? Same thing probably with amitriptyline. It also is antihistaminergic, should not be taken if you have restless legs. The only tricyclic antidepressant that's okay to try for depression is disipramine, mostly because it really doesn't have much antihistaminergic effect. So, the question is then, what antidepressant should I try? Well, Butrin doesn't have effects on serotonin or doesn't have antihistaminergic effects. It largely works through dopamine reuptake. And so that one is thought to be neutral in terms of restless legs. So oftentimes I will suggest that people try this. But, depression is a complicated thing and at times can be very serious. So a person's depression might not respond to Wellbutrin. So I tell my patients, if depression is really impacting you, then you can try other antidepressants such as some SSRIs. And I have many patients on SSRIs, including sertraline, citalopram, and Lexapro. And yes, they can make your restless legs a little bit worse, but they'll make your depression better. So I think if you've got severe depression, it's important to treat that. And if it makes your restless legs a little bit worse, then, there can possibly be some medicines to offset that. So in terms of SSRIs, just a personal gestalt, there's no data to support this, but I find many patients have more luck with citalopram, sertraline, and Lexapro more than fluoxetine, paroxetine, and maybe more luck with those SSRIs rather than this other group of antidepressants called SNRIs, which are selective norepinephrine and serotonin reuptake inhibitors, or serotonin and norepinephrine reuptake inhibitors. And so things like venlafaxine might be more provocative to restless legs than some of these other SSRIs that I have listed here. So I can't really punctuate this enough. This is very important. And just remember, if you have a physician that is not willing to listen to you, you probably shouldn't be seeing that physician, because as a physician, the best physicians realize that you can't know everything, and unfortunately, mistakes get made, and physicians that are not willing to accept that are probably not a physician that you want to have involved in your care. Okay, stimulant medications might make restless legs worse too. The other important clinical issue when it comes to restless legs and depression is augmentation. Augmentation, as many of you know, is a worsening of restless legs, which occurs in the setting of being on a dopaminergic agent, usually for many years and often at high doses. And the worsening can manifest as symptoms occurring earlier in the day, having increased intensity, or spreading to previously uninvolved body parts. And so, of course, augmentation itself with bad restless legs and bad and poor sleep can be associated with depression, but it also is potentially a major issue when being treated for augmentation, because of course the treatment for augmentation includes getting off of the offending dopaminergic agent. And when people are suffering from augmentation, as I suppose that some people in the audience are, especially if they're on a very large dose of drug, as you bring them off of the drug, you can get something called dopamine agonist withdrawal syndrome, and the symptoms may include severe depression. So this is something to look out for. And so I just wanted to spend a little bit of time talking about the study which we recently published in Sleep Medicine. So the objectives of our study was to look at the prevalence of lifetime suicide ideation or attempts in persons with restless legs and also in age sex match controls. And I suspect that there are probably people on this call that participated in this study, because most of the people with restless legs we recruited from the Restless Legs Foundation via RLS Foundation advertisements. So thank you very much for participating. We recruited our controls from an online registry called Research Match, and we included anyone that was 18 to 99 years old. They needed to be able to read English because all the questionnaires were online and were in English. And we wanted to look at people with primary restless legs, so we excluded people with diagnoses that cause secondary restless legs, including multiple sclerosis, Parkinson's disease, renal disease, and severe neuropathy. And we also excluded people with chronic psychiatric disease other than depression or anxiety. And so, we used an online data collection tool called Qualtrics, and we screened our restless leg subject using the Cambridge Hopkins screening questionnaire, which is a well-validated questionnaire. And we also necessitated that the control subjects take the Cambridge Hopkins, and they needed to answer no to having an urge to move while they're sitting or lying down. And so we collected detailed information about their demographics, ethnicity, education, income, marital status, and for the restless legs participants, we measured the severity of their restless legs using the International RLS Leg Group questionnaire, and we also looked at how the restless legs was currently and also in the past. And so one of our main outcomes was derived from this questionnaire. It's the SBQR, or the Suicide Behavior Questionnaire, and the questions are these. So number one was, have you ever thought about or attempted to kill yourself? And the answers you can see are never, just a brief passing thought, have had a plan to kill myself at least once, have attempted to kill myself. Number two is, how often have you thought about killing yourself in the past year? And you can see the answers for that. Have you ever told someone that you were going to commit suicide or thought you might do it? And the answers. And how likely is it that you will attempt suicide someday? And so, by tabulating all the answers to those questions, a person was considered to have a high risk of suicidal behavior if they had a score of 7 or more. We also had them answer the brief lifetime depression scale, which assesses if someone in their lifetime has had a period lasting for more than 2 weeks of symptoms of depression, feeling depressed or hopeless, had little interest in doing things, feeling tired, having poor appetite, basically the symptoms of depression over one's lifetime. So let me take you through this. This is kind of a busy table, but the purpose of this table was basically to show you that, so if you look at the middle 2 columns, you have people with restless legs that were about 192, and controls were about 158. So a p-value of less than 0.05 is considered as statistically different. And so you can see that the groups were comparable in age, they were comparable in gender distribution, being more than 80% female. They were comparable for ethnicity, race, being predominantly Caucasian. Also, marital status was comparable. About 60 to 70% were married. Education was also comparable, as was economic status. Most participants were in the middle high socioeconomic demographic. But you could see that things that were significantly different were people that had a lifetime history of depression that we discovered from the brief lifetime depression scale. So about 2/3 of people with restless legs had a history of a depressive episode, as opposed to about 1/5 of people that didn't have restless legs. About 42% versus 8.2% of people were currently using an antidepressant if they had restless legs. And then alcohol abuse, not surprisingly, since alcohol is well known to worsen restless legs, far fewer, although not an insignificant proportion, had abused alcohol in the past. So let's see. Let me go here. Okay. So what you can see. So here, this graph on the left is looking at, for those 2 groups, the black is restless leg, the gray is control here, and you can see the prevalence of having had a lifetime suicide plan or attempt was about 25% for those with restless legs, as opposed to about 8% for controls. And it was similar for those who were at high risk of suicidal behavior, as determined by this SBQR questionnaire, scoring greater than or equal to 7. You can see that about 30% of patients with restless legs scored as high risk, as opposed to about 10% of controls. So very, very large differences in having had a suicide plan or attempt in one's lifetime, or having high risk of suicidal behavior. This is a kind of a complicated model, but let me see what I have in the next. Okay, so I'm just gonna try to explain this to you, and I'm gonna draw your attention to the first two rows. So these are regression models, and I'm just gonna explain this to you as, so this was the overall, so this model was run in patients with restless legs and in patients without restless legs. And so basically, when it says restless legs, this means that when you compare a person with restless legs to someone that doesn't have restless legs, the person with restless legs has a 2.8 increased chance of having had a lifetime suicide plan or attempt. And then for lifetime depression, well, I guess I should say, so let's do lifetime depression first. So if you have a history of having depression in your lifetime, you had a 4.65 increased chance of having had a suicide plan or attempt in your lifetime. Okay, but even accounting for depression, restless legs was still independently associated with having had a plan for suicide or an attempt of suicide in one's lifetime. So this is key here. So we included in the model because obviously if you have a history of depression in your lifetime, that's going to really impact whether or not you've had a suicide plan or attempt in your lifetime. So we accounted for this lifetime depression, and even after accounting for it, in restless legs, having restless legs was still independently associated with having had a suicide plan or attempt in one's lifetime. A couple months after we published this, there was another study that came out, but this time this study looked at actual suicide and or self-harm. So this data is from a very, very large healthcare system, Truven Health Market Scan. So this was administrative data from a very large healthcare system, which included about 24,000 non-pregnant participants with restless legs and about 145,000 age and sex matched participants without restless legs. And so I'm not necessarily going to go through all of these, but I'm gonna skip down to kind of where the main results are. So when you compared people with restless legs to people without restless legs, in restless legs, let's go back to look at the numbers. There were again 24,000 non-pregnant patients with restless legs and 145,000 persons without restless legs. Of those people, for restless legs, there were 34 cases of either suicide or self-harm, and for non-restless legs, there were 85 cases. And so when you do the math, the incidence rate was 0.35, and this is cases per 1,000 person years. And 1,000 person years is, in a simple way, for 100 years, you multiplied by 10. So kind of like 10 lifetimes, you had 0.35 of cases of self-harm or suicide, as opposed to just 0.11. What is a little bit easier to interpret is you look at this hazard ratio or odds ratio. If you had restless legs and you account for all these other variables such as age and your gender and where you lived and whether or not you had sleep apnea or depression and so forth, if you had restless legs, your hazard ratio of having a self-harm or completed suicide was about 2.6-fold. So concluding, this part, so what we learned from our study is that suicidal ideation and attempts in a lifetime are fairly prevalent among persons with restless legs, occurring in more than about 25% compared to less than 1/10 of age, sex, and demographically matched controls. Suicidal thought or behavior was associated with a lifetime history of depression, and also having restless legs independent of the history of depression. And suicidal thought or behavior was associated with lifetime history of depression and past RLS severity in the restless legs cohort. So after having done this, we're doing a couple of other things. Some of you might be participating in our longitudinal study looking at RLS, depression, and suicidal thought and behavior. We're also currently recruiting for our hormone study to look at these melanocortin hormones. I've been interested in these hormones for over a decade, and just about over a decade ago, we did an animal model which showed that introducing these hormones into rats causes them to have increased locomotion, poor sleep, and periodic limb movements. We didn't look at depressive behavior, but there is a long-standing literature about this, which shows that that these hormones, when introduced into the animal, cause a depressive type behavior and social avoidance. So we're also interested in looking at these hormones with respect to mood and anxiety. So thank you to my group, but restless legs can be a really difficult thing to deal with, and unfortunately, it can be associated with depression and maybe even and yes, even thoughts of harming yourself. If you do have those feelings, in the most acute form, if you're thinking about it, you can call. There's a National Suicide Prevention Lifeline. We'd urge you to call that. Urge anyone who's suffering from this to speak to their caregivers or their healthcare providers and get the appropriate help by seeking help from a psychiatrist and or a psychologist. These things are vitally important if you are unfortunately suffering from depression. Thank you very much for your attention.
All right, thank you, Brian. We've got some questions that people submitted with their registration. The first is there a connection between diet, depression, and RLS?
Yeah, this is an interesting question, and I think there's a lot about diet and even restless legs that we don't know about. But I think that there probably is. I'm learning from my patients that foods high in simple sugars can lead to worsening of restless leg. But I think it's important when you have restless legs to not only be mindful of the symptoms of restless legs, but also of sleep. And so I think it's very important to think about caffeine intake. I think it's important to think about sugar intake. I think the best advice I can give is just to have a diet that's of moderation. It's okay to have simple sugar in moderation. Perhaps it'd be better, left toward the morning rather than the evening. But just a diet of moderation.
Is there a connection between methadone use for RLS and depression?
Yeah, this is an important question. I think the short answer is yes, but it depends, because depression can certainly happen with methadone. Fortunately, it doesn't happen with everyone, because there are many patients that have tremendous response to methadone, and their restless leg symptoms are basically gone with methadone. These are the lucky ones. But there are some people that the symptoms are decreased with methadone, but have depression. I've had a lot of patients that can't be on methadone because of depression. Some people will just say that they cry a lot more easily, or have feelings of doom, or really severe sadness. So certainly this is a side effect of methadone. So if you're on methadone and you feel depressed, you should bring it up to your provider as certainly a possibility of that's what's causing it.
Are there currently ongoing research projects for severe RLS in relation to chronic depression, and where may I volunteer?
Right. So I'm not aware of any treatment studies, so any kind of clinical trials to treat RLS/depression. I mean, we are conducting kind of a longitudinal kind of observational study, but we we would not be able to offer any type of treatment. So um, so I guess the short answer is kind of yes, but I'm not sure what type of research the person asking the question was looking for.
Okay, are there ways to fight and control the depression without drugs?
This is a difficult question. Yeah, I mean, the answer could be yes. Um, so certainly a healthy lifestyle is, and one including exercise, um, is very it could, so it's very possible to treat depression in that way. But if the depression becomes very severe, and certainly if there are any thoughts of self-harm or that life is not worth living, I think it's probably better to just think that, to think about all the potential things that can help, and medication is just one of those things. So in addition to, a healthy lifestyle, seeking the care of a psychiatrist and really considering getting on a medication, I think is very important.
Aside from lack of sleep, does the root cause of RLS cause or make depression worse?
Yeah, and this is something that we just don't know. So, I mean, I talked a little bit about mechanisms in the study that I conducted previously, looking at poor sleep and maybe PLMs, but that's an academic study. We don't really know what the basis of restless legs is itself. So, again, with the study that I'm conducting now, there's some past data to suggest that these hormones might be associated with avoidance behavior. And what I'm trying to do is figure out if restless legs is associated with increased levels of these hormones. So it's possible that there is some biologic rationale here, but we're a long way from really understanding it.
Are there any positive results for RLS and clinical depression with the use of transmagnetic cranial stimulation?
So I'm not familiar with any studies looking at both of those, but I know that TMS has been shown to be helpful for depression itself, and I believe that there is a restless legs study that has shown some benefit uh, uh, of TMS for restless leg symptoms, but I don't know if a study has combined those two things.
Can RLS lead to depression even if the symptoms are managed via medication?
Yeah, I don't think we know the answer to that, but I would say very possibly. Because so even if there is uh, there are lots of things that happen in sleep. Even if you think you're getting good sleep, you might not be. So this is the rationale for why we looked at periodic limb movements, because someone could have hundreds of periodic limb movements across the night, but feel like they got good sleep. So I think it is very possible that one could have depression and it be in some part caused by restless legs, and have it even if the restless legs is controlled, but we don't know for sure.
It appears there is a correlation between depression and all conditions for which there is no cure. How is RLS unique in this?
Yeah, depression is a very common thing, and so whenever you have a common disease or health entity, it's usually caused by many different factors. And I think that is true of depression, because you could be depressed uh, if you have a death in the family, or if you if you were bullied as a child, you could be depressed as well. So there are many, many different reasons why people can be depressed. I think that in restless legs, the symptoms of restless legs suggest that there's some biology that joins all or at least many people with restless legs, and the fact that so many of people have depression that have restless legs suggests that there might be some underlying molecular mechanism that not only joins the symptoms but also the mood symptoms as well. So I think that there might be some some rationale to look at this and to think that maybe that if there were a different treatment that really addressed the root cause of restless legs, that symptoms such as depression could get better.
My husband suffers from RLS and depression. I'd love for the speaker to share ways that I can provide support and care for him.
Yeah, well, thank you for that question. I'm sorry to hear about your husband. I think, and it sounds like just by the fact that you've asked this question, it sounds like you're very caring, and obviously someone that's suffering with depression and restless legs needs to have someone to talk to and understand, at least be able to listen to what they're going through. So that is probably one of the most important things. But to maybe be a sounding board about potential solutions. If your husband does not have a relationship with a psychiatrist and psychologist, I think, maybe persons with depression often lack initiative. So maybe, looking on the internet for numbers for psychiatrists or psychologists can be helpful. Brainstorming things that help with his depression and or restless legs, whether it be exercise, clearing some time out of the schedule to go for a walk. That type of thing, I think, can be helpful.
How bad should my depression, anxiety get before I push for medications?
Yeah, so I think that it's unfortunate there's a stigma to medication, to antidepressant medication. I think if you're thinking about it, then I think deep down you probably know the answer to that. If you're struggling enough to be thinking about it, probably you would benefit from it, and I think you should really highly consider it. So if you feel like you're struggling at all and you're thinking, oh, maybe I should, then probably you should.
All right. Please share with us the current RLS research that you are working on and how individuals can volunteer for your study.
Yeah, thank you for asking this question. So, I've been working on the potential relationship between restless legs and the melanocortin hormones for a long time, but only recently, just in the past 3 months, got the good news that we have been funded by the Department of Defense. And so this, I hope, will be transformative to me because I will be able to recruit persons with restless legs. And so basically what we are doing in this study is recruiting patients with moderate to severe primary restless legs, primary meaning, no multiple sclerosis or Parkinson's disease, that have moderate to severe restless legs that are not on medication for restless legs. I know that is very difficult to find because most patients that have moderate to severe restless legs are taking medications for the restless legs. So we're looking for people that are not taking medications, or if you do have moderate to severe restless legs, if you're willing to temporarily come off medication to take part in this study. And so part of the grant is going to help offset costs for travel. So some of the main parts of the studies is we need to see you because we need to take your biospecimens and measure the hormones. And so we have a significant portion of the funding is going to be allocated to help offset cost of travel if people are willing to travel from different parts of the country to New Haven, Connecticut. So that is the main area of research that I'm currently doing with restless legs. Again, we're also doing a longitudinal study in which we're tracking kind of mood symptoms across a number of years with people that have moderate to severe restless legs. We're also doing a study. We're completing a study which showed an interesting association between hypothyroidism and restless legs, because I learned from a number of you listeners, because many of you seem to have hypothyroidism. So we did a study, and probably many of you participated in this, where we recruited, again, restless legs people, mainly from the Restless Legs Foundation, and found that there was about a twofold increased chance of having hypothyroidism if you had restless legs as opposed to not restless legs. And so now I'm in the kind of the planning stages of figuring out what my next research study is going to be, because I'd like to further study this association as well.
Wonderful. And on behalf of the whole RLS community, Brian, we sure appreciate all the work that you're doing in research to help us find better treatments and possibly a cure. So our next webinar will be on Wednesday, January 22nd at 2 p.m. Central. Dr. Jeffrey Dermer will be discussing technology and sleep. Visit rls.org to register or attend. And thank you everyone who attends today's webinar. Have a wonderful day.